Hello and welcome. My name is Brigitte Anderson, and I support program management for FARE, Food Allergy Research and Education, a nonprofit organization based in McLean, Virginia. In honor of Food Allergy Awareness Week, I'd like to commence a discussion today to help people learn a little bit more about food allergies, how they're diagnosed, how they're treated, and how people can consider participating in research. In order to facilitate that conversation, I've brought two wonderful guests with me today, Dr. Stephanie Leeds and Dr. Trisha Lee. Dr. Stephanie Leeds is an assistant professor of pediatric allergy and immunology with a specific interest and expertise in food allergy. Dr. Leeds graduated summa cum laude from Tufts University with a degree in literature, and she studied medicine at the University of Chicago. She completed her pediatrics residency at the Children's Hospital of Philadelphia, and she completed her allergy and immunology fellowship at Icahn School of Medicine at Mount Sinai. Dr. Leeds has published research on broad allergy and immunology topics, but she is most interested in the natural history, clinical manifestations, novel treatments, and educational challenges of food allergy. Welcome, Dr. Leeds.
Thank you.
Dr. Trisha Lee is an assistant professor at Emory, and she sees patients at Children's Healthcare of Atlanta Allergy and Immunology Clinic. She received her medical degree from Mercer University School of Medicine and completed her internal medicine and pediatrics residency at the University of Louisville, where she was the chief resident, and then her allergy and immunology fellowship at Icahn School of Medicine at Mount Sinai. She is a board certified physician with the American Board of Pediatrics and the American Board of Allergy and Immunology. Her clinical interests include food allergies, environmental allergies, asthma, and atopic dermatitis. She is currently working on multiple studies with her mentees to include researching barriers for diverse families to participate in food allergy research, restaurant access to epinephrine auto-injectors, and early peanut introduction in a vulnerable population. She has published articles and presented at national meetings about immunodeficiency, food allergy, and infectious diseases. Dr. Lee is passionate about connecting with local communities to improve the lives of food allergy families through evidence-based patient care, education, and advocacy, and she hopes to be an active member in the research community that advances food allergy care equitably. Welcome, Dr. Lee.
Thanks.
Okay, so first things first, to make sure that we all have a common understanding, can you please define food allergies for me and our audience, Dr. Leeds?
Sure. So what the common person thinks of a food allergy is an immune-mediated reaction to a food within an immediate time frame, and typically that means minutes to hours after exposure. And there are common signs and symptoms of this allergic reaction that include hives, swelling, difficulty breathing, vomiting, all the way up to life-threatening anaphylaxis. The immune mediator for these reactions is something called immunoglobulin E, or briefly known as IgE. And there are a variety of non-IgE mediated food allergies, which we won't focus on today, but those include diagnoses such as eosinophilic esophagitis and food protein-induced enterocolitis. But when we speak about food allergy, for the most part, people mean the conventional IgE-mediated type of food allergy.
Thank you. And for both Dr. Lee and Dr. Leeds, as a clinician, can you tell me what sparked your interest in food allergies? Dr. Lee, can you tell us first?
Absolutely. So I was in residency doing internal medicine and pediatrics, and I had the opportunity on the pediatric side to be the physician at a summer camp. This summer camp was called Center for Courageous Kids, which is in Kentucky, and it's specific to patients who have diseases. So for example, I was there for the week of diabetes. I also learned that they had a food allergy week, and I can't say that I knew a whole lot about food allergy, or at least I didn't appreciate sort of the barriers and struggles that food allergy families can have on a day-to-day basis. But just being at the diabetes camp and understanding, how social of a society we are and how much that includes food and eating and how frequent these discussions are, it was sort of the start for my interest in food allergy. About the same time, I was deciding to subspecialize and apply for a fellowship, and ultimately decided on allergy and immunology. Initially, it was actually more the immunology side that really piqued my interest, because it seems that we know very little bit about the immune system. And sort of similarly, really at that time, it felt as if we knew very little bit about food allergy. My mentor, Dr. Jerry Lee, who is actually now here in Atlanta practicing with me, initiated and stated that Mount Sinai had the best program director who was just lovely and had a great immunology side of things. Turns out they also have an amazing food allergy team, and truly the founders of food allergy, particularly from a research side, are there. So I was fortunate to be trained by some of the very best food allergists that exist in this world, but then also had this amazing opportunity to work in what was truly just a food allergy clinic. And the more I get to learn about these families and meet these families and understand their lives, I fell in love with the ability to work with these families, whether it's, from that initial new diagnosis to then having to navigate, social activities like birthday parties and soccer and going to school. And then these families would have their second child and talking about prevention for their second child. So really just appreciate being a part of these families' journeys, and is a field within allergy that allows us to have such close connections to families.
Thank you, Dr. Lee. Dr. Leeds, can you share your story?
Sure. So there's going to be some commonality with Dr. Lee. As you stated in our bios, we actually trained together at Mount Sinai. So a lot of those exposures and mentors are similar for me, but sort of my personal journey, it all starts with great mentors. When I was at CHOP, there were wonderful clinical immunologists who really turned me onto the field. And it wasn't until I started my fellowship at Mount Sinai that, as Dr. Lee alluded to, really just incredible researchers and clinicians in the domain of food allergy who opened up the multifaceted ways in which a clinician can get engaged in food allergy. Everything from basic science research looking at why food allergies exist to clinical care and clinical trials in terms of thinking about how to treat food allergies, looking at biomarkers, different tests that we can do to diagnose and predict someone's food allergy pathway. So there's just so many opportunities for advancement in the field. I think we've come a long way, but we still have a long way to go. And so I'm just very excited by the prospects that lay ahead. And sort of the other thing that I think Dr. Lee would probably agree with me on is we were lucky enough to be trained in a concentrated facility with real thought leaders and experts in food allergy. And we had a significant exposure to not just the bread and butter food allergy patient, as we say in medicine, but also really complex and complicated patients. And I think that breadth of exposure allows for a confidence in practice that perhaps not everyone feels comfortable with. And so I think even within allergy and immunology, you will find clinicians who, through no fault of their own, just don't have exposure or experience in food allergy and will make statements like you should blanket avoid a wide variety of foods. Whereas I think those who have an interest in food allergy can really get into the nuanced sort of nitty-gritty details of how to most effectively and appropriately manage a food allergic patient. And I like that challenge. So that's sort of the path that led me to this point.
Thank you. You brought up an interesting point when you mentioned food allergy treatment. It's commonly avoidance that people see as kind of the way to treat it. But Dr. Lee, can you sort of elaborate and just tell us beyond avoidance, how else is food allergy treated?
Yeah, so certainly the standard of care is still avoidance, carry on your epinephrine autoinjector, and then monitor for resolution of that allergy. You're really getting into an exciting time of food allergy as some actual treatments are coming to the field. And so we have the first FDA-approved peanut allergy treatment called Palforzia, which is starting to standardize this concept of oral immunotherapy. And really for several years, even before Palforzia, several physicians have been doing oral immunotherapy and certainly continue to do it outside of just peanut. Oral immunotherapy is starting with a small amount and gradually increasing that exposure of the allergen, very similar to maybe what is more commonly understood like allergy shots. You're going to be eating the food, and it is eating the food every single day. And generally, you're going to go back to the office when that amount is increased. You get to a maintenance amount, which you'll then continue once again for every day. And for my patients, I'm telling them they're doing this treatment every day until something better comes down the pipeline. So the hope is that some of these other options that will come down the pipeline will help other food allergens. Maybe multi-food allergic patients could take one treatment that would help all of their allergens as opposed to taking multiple powders. And I think what we may also see come into the field, which is being researched, are some of these monoclonal antibody injections, which will hopefully lower thresholds of reactivity.
Thank you. So I'm curious, just sort of based on the information you've both shared about sort of your patients, patient populations, the diversity of experience with food allergies, what do you feel are some of the common misconceptions that people have about food allergies?
Yeah, there's a lot of them. So we can start with some of the more basic ones. So I think a common misconception I like to debunk is that we can use testing to, number one, diagnose a food allergy, that blood or skin tests alone can diagnose a food allergy. And that two, these tests can tell us whether or not someone has a mild or severe allergy. So blood and skin tests are the ways in which we build evidence to support a hypothesis of food allergy, but truly the gold standard of food allergy diagnosis is a direct oral challenge. So what happens when the patient eats the food? Food, skin and blood tests have what we call pretty good negative predictive values. So if they're negative, we generally believe that they are true negative tests, but have pretty poor positive predictive values. So without a history to use as a lens through which to evaluate these tests, a positive test may very well be a false positive. And so, it's really important that, number one, patients aren't being tested with broad food allergy panels. You are very likely to pick up some false positive results if you screen someone for a huge variety of food sensitizations. And the other important point to make is that if testing is done, it really should be interpreted by a board certified allergist. And so I don't want parents to despair if for some reason food testing is done. A common example, a child has eczema, someone sends a food panel because they say maybe foods are triggering their eczema or even causing their eczema. They come back and they've got a huge number of positive tests. These patients are sent to our offices, and I feel the sense of relief at the immediate discussion of, okay, you tested positive for egg, milk, wheat, but when's the last time that your child ate these foods? Oh, 2 weeks ago, but then I stopped when these blood tests came back. And I immediately tell them, please bring those foods back into the diet. They are not allergic. They ate the food. They didn't have a reaction. Does not matter what the blood or skin test says. So I would say that is probably one of the most common myths, is that testing is a perfect science that can diagnose food allergy. And I'll briefly touch on the other point that I made, which is that there is no test that can tell us whether or not a food allergy is, quote, mild or severe. So we know that there are so many factors that go into how severe a reaction might be if someone who's food allergic is exposed to a food. And that's everything from the dose of food allergen ingested, so the amount of food ingested, their immune status at the time, if they're sick, if they have a fever, if they exercise, if they have pain medications at the time, if they're menstruating. So the list goes on and on about all different sorts of cofactors or augmenting factors for food allergic reactions. So there's no single test that can account for all of that. We prepare all of our patients who we diagnose with food allergies with an emergency action plan and an epinephrine autoinjector. And that's because food allergy is somewhat unpredictable. We can't say for sure whether or not someone is going to have a mild reaction or a systemic reaction with exposure to a food allergen. So we want everyone to be prepared with a plan and appropriate medications to treat sort of anything on the spectrum of these reaction phenotypes. So I think that's probably one of the biggest misconceptions.
Yeah, and I'll build on that in that, in medicine, we like to think what are the risks and what are the benefits, and really all choices that we are choosing. And I think a lot of times what is not discussed is what is the risk of avoiding this food if you're not currently having an immediate life-threatening reaction to it. So if there's some concern that this food is contributing to behavior or skin or gut, but it's not an IgE-mediated reaction that could lead to life-threatening reaction, then ideally, I think most of us allergists would encourage the family to try to keep the food in the diet, because certainly the risk is if you're not eating the food, then you could develop an immediate life-threatening reaction to that food if you haven't already. So it's good for the body to see the food and not forget that they are okay with it. So we certainly encourage to keep foods in the diet if we are able to. The other sort of perspective that I give families when they come in to see me, because a lot of times their question is, do they have food allergy? But truly, it's all in the definition. So, what I would define as food allergy is an immediate life-threatening reaction. And that generally is consistent, meaning a reaction is always going to occur when you eat that food. And in my brain, I have that in one bin, and then I have other food reactions in other bins. So like milk and lactose is in a separate bin, which our food, skin, and blood tests won't predict, or celiac disease, which is due to wheat and wheat protein, but it is a blood test or a scope as opposed to our skin test and blood test. So just understanding really the lack of what our testing can do, and that it can only predict immediate life-threatening reactions. Other misconceptions, I think, are around the foods that can cause reactions and sort of severity of those reactions, meaning milk, egg, and wheat are actually probably more common in childhood, but most kids are going to outgrow those as opposed to adulthood. They're still left with their peanut, tree nut, fish, shellfish allergy. This question of, one food being more severe than another, it's interesting in some of the milk, OIT, oral immunotherapy research, there have been some really severe reactions. A lot of times peanut gets this bad rep as if it's the worst reaction possible, but certainly other foods can cause severe reactions too. And then that concept and fear of, how common is actually death from a food allergic reaction, and it's rare. And then there's this wonderful picture, I wish I could immediately show it, but it is looking at sort of the likelihood of being struck by lightning. It's going to occur more commonly than a food allergic death. Obviously, it doesn't undermine the stress, the concern, and certainly the need for avoidance if you are allergic to the food, and then certainly carrying around your epinephrine auto-injector. But luckily, deaths are actually rare. And then this concept of reactions and every exposure, they could be worse. And Dr. Leeds really touched on this. A lot of times has to do not just are you allergic and did you ingest the food, but these other factors and some of these that are cofactors that can even lower your threshold. So, every day that you eat an allergenic food, a different reaction could occur. A reaction is probably always going to occur if you are truly allergic to the food, but the severity of the reaction is unpredictable. So this sort of old wives' tale that with every injection, the reaction is going to be worse is not necessarily a true statement.
Thank you. There's so many different misconceptions I think I had now that have been sort of debunked, and the truth is coming out. So this is very helpful. And the statistic around being struck by lightning is more probable than a mortality event related to food allergy. That's a very telling statistic.
It's a really powerful statistic. And I would say many of us, I use it in clinical practice all the time. And again, I see the sort of light bulb go off and sort of a change in demeanor where I feel like it's really powerful to empower parents to walk around, feed their kids without this looming fear hanging over their head. And so, I do think that using examples like that can be really meaningful in a clinical context.
Absolutely. So it seems like, at least for the first couple of questions that I've asked, the conversation we've had, we've focused on sort of the clinical encounter. So when a person may suspect they have food allergies, how they get diagnosed, how they may potentially get treated. We've discussed some of those misconceptions that exist in that clinical setting. But as we shift a little bit toward research, can you tell us why research on food allergies is important? Dr. Leeds, can you answer that for me?
Sure. So first of all, just to set the stage, there's all different types of research, right? There's clinical research, there's basic science research, which is what happens in a lab when we look at cells and how cells interact to create immune responses. There's survey research, there's a broad number of ways that you can use a scientific method to try and answer different questions around food allergy. And the bottom line is that we don't have it all figured out. But we know that if we are able to test some ideas in a rigorous way, that eventually the evidence that we accumulate through research is most likely the means through which we will wind up with new treatments and potentially even a cure. So if we don't understand exactly why food allergies exist, what causes food allergies, there really isn't great hope for us to figure out the ways that we can manipulate or change the immune system so that food allergies cease to exist. I think that there is always the hope that we can expedite treatments, but to make sure that this is done in an effective and most importantly in a safe way, there really has to be research behind some of these clinical initiatives that people get excited about.
Thank you. And sort of just following up then, thinking about it from the perspective of a patient, what are some of the benefits of participating in a research study or project?
So obviously there's always the altruistic notion of contributing to the greater scientific literature and knowledge base. And again, that always promotes movement forward in terms of treatments and cures for diseases. But, interestingly, there's also a phenomenon out there by which patients who participate in things like clinical research tend to do better overall, even if they're, for example, in a placebo-controlled trial where some of the patients are randomized to receive a treatment and some of the patients are randomized to receive a placebo treatment or sort of a sham treatment. There's some pretty good evidence that just being in a clinical trial leads to better health outcomes. Now that's probably or potentially due to increased interactions with the medical field, more systematic and protocolized standards. But I think that beyond the altruistic benefits, there probably is individual benefits. So I would say for all of those reasons, it's important if patients want to be involved in research to have a really in-depth, nuanced conversation with the primary investigator to figure out what are those potential benefits, not just to society, but to me. I think it's an important conversation to have.
So then following up, and since both of you do research as part of your professional work, can you talk about some of the concerns that you've heard from patients around participating in research? Dr. Lee, can you begin that?
Yeah, so, I always try to put myself in the shoes of patients. And as a busy working mom, I think the biggest concern that comes to my mind is time. And so, for a lot of the clinical trials, the number of visits that it requires can just be very time consuming. And then if they're in a trial where they're taking a medication, the amount of documentation that's required, and that, maybe you're monitoring diet or you're monitoring taking a medication every single day. And then if you're having side effects. So I do think it can be burdensome from just a time perspective, physically trying to get somewhere versus even just on your day-to-day life. For a lot of the clinical trials, doing a challenge is necessary so that we can make sure we are enrolling only, food allergic patients. And that can sometimes be a concern for families and patients. It's interesting though, in my experience now with some of these clinical trials, it's been surprising to me how useful some of these challenges are, meaning some families will come in, they'll do a challenge because they want to be in the study, but they actually don't qualify for the study because they do so well on the challenge, meaning they don't react at such a minimal dose. And even though we think that child may still be allergic, because for example, if we then try to do the challenge on the clinic side, which is a much higher dose, then they potentially would react, that information is useful for the family because they know, okay, well, they're at least body's not going to react at 100 milligrams or 300 milligrams. So the concern for cross contact may be a lot lower. So that may be useful, though that fear of reaction is certainly possible. Another family interaction that I've had that's been surprising is a 17-year-old boy who is just petrified of generally healthcare. So certainly injections and blood draws, but really just any interaction. And the mom has so much concern that he's not going to seek out medical care as he's transitioning from sort of a child to adulthood when he needs that care. And they are finding that this experience is certainly educational, and it's allowing him to work through some of those fears. But I do think that, sometimes there are extra blood draws, and because they're doing these challenges and we're eliciting a reaction, for example, they may need, an epinephrine injection. And then certainly just the risk of going into a clinical trial and receiving a placebo. So you're putting in that time and you're actually not getting anything after maybe a year's time. Some of the studies have extension studies so that they are then getting access, maybe still sooner than they would have otherwise, but it can be a lot of work and effort to be receiving the placebo. And I think that can be frustrating. Some of the things that I'm sort of personally interested in looking at the data is the barriers for diverse families and what their interests and concerns are into entering into really any type of research. And so sometimes when it's surveys or collection of information, there's concern with access to that information from parties that shouldn't have access to that. So that just gives you a sort of wide view of the experiences that I've had with sort of conversations and families throughout research.
Thank you.
And I would also say most commonly, and I agree with Dr. Lee, once I became a mom and had 2 children and sort of entered into the medical world as a parent, I completely understand the concept that no one wants their child to be a guinea pig, right? This is like the common thing we hear when it comes to any new treatment or new medical innovation. And I think that the answer to that is the corollary of what I said before when you ask about what's the benefits. And I say you have a nuanced discussion with the primary investigator about benefits for your child. So the opposite part of that discussion is you should have a nuanced discussion with the primary investigator about risk. And truthfully, for many types of research, there is minimal or low risk. Now, I think that any research where there is more than standard risk or more than minimal risk involved, investigators are usually very upfront about that and give very specific and explicit information. But I really encourage patients to have, again, a deep and nuanced conversation with an investigator about both benefit and risk before making any decisions about research, because a lot of times just that education and increased knowledge around these topics of research can really inform decisions.
Thank you. I think in the answer to that question, both of you have emphasized the aspect of sort of clinical trials and some of the concerns that people think about in that context. But I realize that sometimes people don't realize there's other aspects of research that they can consider doing, like patient-reported or surveys and whatnot, that are maybe seen as a little bit less invasive or time-consuming or sort of like lower risk and involvement. So with that in mind, Dr. Lee, can you tell us a little bit more about what patient-reported outcomes are for our audience and why they're important to research?
Yeah, so patient-reported outcomes are really using that terminology. So they are, information directly from the patients. And this is a type of research that, has been done for a very long time, but hopefully as we have evolved has improved. I think there are some concerns that historically some of the patient-reported outcomes may have been skewed, maybe not so subjective. Certainly we've brought up this concept that what I define as a food allergy may be very different than what the general public defines as a food allergy. So even just finding the specific cohort of patients that we are trying to research can sometimes be difficult with patient-reported outcomes. But I think, in this era where we are talking about shared decision-making and patient-centric care, that patient-reported outcomes are maybe more important than ever before. I think food allergy has been a great example of this. When I started in this food allergy research world, this concept of oral immunotherapy, the goal was to cure food allergy, and comes to find out, families of food allergy patients, they aren't necessarily looking for their child to eat a peanut butter and jelly sandwich. Their concern is just, how can we protect our child from having an accidental ingestion and then secondarily having a severe reaction? So the shift in oral immunotherapy research has certainly been, let's protect from cross contact. We don't necessarily need to cure this child. And I truly believe that this shift has been because of families and their voices. So I think as we continue down, this pathway of research and what should we focus on, hopefully patient-reported outcomes will be a huge player into the direction that research continues on. And it allows us to really be able to include perspectives, burden, day-to-day life things that the researchers may not be understanding and certainly aren't living, but these families are.
Thank you. So then my next question then is, on that spectrum of participatory research, there's also this aspect that we call the patient registry. And so this question's for you, Dr. Leeds. Can you define patient registries for us and tell us what type of knowledge can be gained from patient registries?
Sure. So patient registries, broadly speaking, are collections of secondary data, meaning that we're not directly observing data or facts, but similar to patient-reported outcomes, they're sort of secondhand knowledge around a specific group of patients with a shared diagnosis. So there are food allergy registries, of which FARE has the largest, and these repositories house lots of different details about patients' experiences, potentially, historical test results, reactions, treatments, and it gives us the opportunity to, in a systematic way, amass large data sets across diverse people in distinct geographic areas to try and figure out what are the trends, what are the characteristics, what are the outcomes of food allergy that we see in the real world. And as Dr. Lee alluded to, patient registries are incredibly useful for us to debunk myths, to give best guidance advice, to create protocols, to think about direction of research. So these are vitally important collections of data that really propel the field forward.
Thank you. This has been incredibly helpful. As we reach the end of our conversation, I just have two more questions for each of you. Can you tell us more about the ways that a food allergic individual and their family can get involved in research? Are they typically approached by a doctor? Should they be actively seeking these trials online, Googling? Like, what is the best course of action for someone to consider? And this is for both of you, so you both feel free to answer.
Yeah, I'm happy to start. I'm so fortunate to be at a center where we have a significant amount of research. And so there are certainly flyers when you come into our clinic, we're giving you handouts. And then on our website, there are specific areas where you can search for all types of research, but then also very specific to food allergy research. I think it's probably going to depend on every single patient and what allergists they see and the connections that they have. So for example, a lot of the private practice allergists within Atlanta, though they may not be doing a significant amount of research themselves, we have close communication with them, and we're constantly updating those allergists as to the programs that we have. So some patients may need to seek that out depending on how far away maybe they are from an academic center. There are certainly other clinical trials that are being done, not only in academic centers, but also other private practices that have their own clinical trial networks. I think if you can get that information from some of your local networks as well. So I know FARE on their website has access to different clinical trials, as well as anyone can go to clinicaltrials.gov and you can search if you're peanut allergic or if you're sesame allergic, and then it gives you an idea of the type of research that is being done, who is recruiting, where they are recruiting for. When we were in New York, Stephanie and I we had patients really coming from all over, certainly to be seen on the clinic side, but then we would also have patients come from very far just to be a part of a research study. And that has been sort of my similar experience here. And that, we have some patients, they're coming from Florida and they're driving like 8 hours just to continue to be a part of this research study. So I do think that you can seek it out, and you can certainly find those resources online, with clinicaltrials.gov probably being the best resource.
Thank you. Dr. Lee, any additional thoughts regarding awareness of participatory research for patients and their families?
I think Dr. Lee summarized it quite nicely. The truth is, most specific research endeavors are happening at large academic sites, although there are private practices, particularly in the domain of oral immunotherapy, who are engaged in research and clinical trials. But as we stated before, you can go onto the FARE website and become part of the voluntary patient registry. That will certainly be minimal risk, low time commitment, and still contribute to research in a significant way.
Well, this has been a fantastic conversation, Dr. Lee and Dr. Leeds. I just want to leave you with one question, which is, what final thought would you like the audience to remember regarding food allergies?
I can start, and I would just say, I think a final thought would be that I never want a food allergic family to feel like they are alone in this journey, and that there are physicians and even subspecialists within allergy and immunology who are solely focused on trying to figure out new treatments, advances in diagnostics, and really it's our honor to do the work.
Yeah, and I think sort of my final thought would be to seek out a local network. I think through local networks, we are able to provide education to the general public, as well as really push through on an advocacy front. I don't think I really understood this until I became a mom, and that I really appreciate finding my tribe and that support, and really value being able to talk to someone else who has walked through my shoes. So I think that is a huge resource for families.
Dr. Leeds and Dr. Lee, this has been a phenomenal conversation. I think it's going to benefit so many people beyond Food Allergy Awareness Week and beyond. And I really just want to thank you and express gratitude on behalf of myself and FARE for this conversation. Thank you.
Thank you so much for having us.
Thanks for having us.
Thank you. And for those of you that want to learn more, I would encourage you to visit the FARE website, which is foodallergy.org. Thank you so much.